Hello and welcome to Middlebury 5-0. I am your host, Officer Chris Mason, and with me in the studio today are Lynn Boggs and Ron Hallman. Welcome to the show.
Good afternoon,
Nice to be
Chris.
here. Thanks for inviting us.
My pleasure. And I know that you are both affiliated with Porter Hospital, but I'm not sure exactly what you do at Porter Hospital. So perhaps the first question is, what are your roles? What are your jobs at Porter?
My role is the president of the hospital, and I've been there about going on 8 months now.
Okay.
Yes, moved here from North Carolina, so it's a wonderful community and a great place to be.
That's a big transition.
It was a big transition,
Yeah.
certainly. Yes.
But what about you, Ron?
So I'm the Vice President for Public Relations and Development. So my role is basically fundraising, public relations, marketing, a little legislative liaison work, special event planning, and so forth, and basically working with Lynn to try to get the word out about all the work we're doing. And the other thing it's important is actually we actually use the term Porter Medical Center because a lot of people don't realize that Porter is more than the hospital. We've got a 105-bed nursing home too.
Yes.
So the nursing home is another part of our organization. So that's why we sort of have the big term Porter Medical Center. So
And we also have 13 physician practices and 60 employed providers in those practices. So it's quite broad, and we cover a lot of care throughout Addison County, not just in Middlebury, through those physician practices. So
it's like a whole network.
it is an entire network.
yeah.
Like a medical community.
Right.
It is. It
Yeah.
is.
right.
Little
Yes.
village.
It is a little village,
Right.
and we have some wonderful providers. We have a lot of primary care providers, and primary care is particularly important within a health system and within a community as we move towards healthcare reform.
Right.
Primary care is going to be the site at which a lot of folks in the future will receive most of their care, because the effort at the federal level and state level is to really get cost out of healthcare.
Right.
And you do that through keeping people well, rather than letting them get sick and use expensive health care.
That makes sense.
So we are really trying to slant all of our efforts and our future planning towards how do we create the best ambulatory healthcare model possible. And most of that is housed in our primary care offices.
So that's where the prevention work would be done.
Yeah, so you as an example, if you were a patient with diabetes,
Okay.
your primary care physician would monitor your blood work routinely, would make sure that they're checking you for all the things that could happen to a diabetic patient, and they're monitoring that along the way so that you don't have an opportunity to really get sick or to get into crisis.
Right.
And that keeps you out of the hospital and keeps you well.
It seems like it'd be better for everyone.
It's common sense medicine.
Right.
Yeah, absolutely.
And the interesting thing, though, the tension in that comes that historically hospitals and physicians have been paid to do things to patients, to
You make that sound so sinister.
well,
Do things,
to give you an X-ray, a lab test, an
Sure.
exam, admit you to the hospital, to actually perform procedures on you. That is how the payment has been.
Right.
The state and the federal government are moving toward a new system where the incentive will be for providers to avoid doing things to you.
Okay.
The incentive will be, the financial incentive will be to keep you well.
Right. So on some level that seems counterintuitive, but it
Well,
makes complete sense. Like you would think of
Right.
people getting paid for doing something,
Right.
but it makes absolute sense that people would be rewarded for preventing.
Well,
If you
having
think,
to do
and if you
things
think
that-
about the labels attached to what we've been in for our entire history and what we're going to, you'll hear fee for service or a volume-based payment structure versus where we're going, which is value-based or population-based care. So it's a drastically different model of care. It's also a different payment methodology. But those of us who have been in healthcare a really long time, as I have been, and I'm a nurse by background,
Right.
this is completely alien to anything we've ever known in healthcare. And so we're all trying to understand how to do this thing.
And the interesting thing is that as the state begins to roll this out incrementally with pilot projects and experiments and quality initiatives, they're asking us right now to participate in projects where we are starting right now to try to reduce volume. To do public health programs to keep people out of their emergency department, to do better care, transitions of care so that we avoid readmitting someone to the hospital, doing all of the things that are in the best public interest, in the best interest of the patient and so forth. But while we're doing these things and having some success, we're still getting paid
in the old
way.
In the old way.
So when we reduce,
we're hurting ourselves.
Okay.
When we reduce our emergency department volume right now, we're actually doing so at our own financial risk.
Right, because the system has traditionally had a vested interest in people being sick.
So the financial incentive hasn't changed, although we're trying to change the operational system. So Lynn always says we've got sort of 2 feet in 2 different canoes right now.
Right.
And we're on the lake, and we're trying to keep afloat, but we're on 2 different payment, 2 different incentive systems. So, and the state just last week announced that they're going to move forward more aggressively with this incentive, and they haven't figured out all the details yet, but it is coming. And so this is why it's such an interesting and challenging time in healthcare in general, and for small organizations like Porter especially, because we don't have a lot of margin for error. Right. If we go too far out in one canoe and end up reducing our volume so dramatically that we're very successful in the new system, but we end up reducing it so dramatically before the payment system changes, we will end up, being financially devastated by doing the right thing. So this is what keeps Lynn up at night. This is why we're trying to navigate this and continue to serve the community, which is the number one thing, but also to continue to exist, which is also the number one thing.
Right. Hard to serve the community if you cease to exist.
Right.
Yes, and that's really, and that is our mission. I mean, our mission is to deliver healthcare services to the community. That's the number one reason we exist as a nonprofit.
Right.
And so when we look at how to do that in a small critical access hospital, so we're independent, we're a small critical access hospital, like any business, we have to pay our bills, we have to pay our staff, we have to buy equipment and supplies, and so we have to make the numbers work as well as provide exceptional service and excellent health care. And that's a tough formula for a small hospital. So as we try to understand how to navigate, we have to look at our own cost structure at Porter. And what the state is mandating through the Green Mountain Care Board, which is the quasi-legislative group that oversees hospitals in the state, we're mandated to reduce our cost. And so we're going through our organization and finding ways to reduce our operating costs so that we can continue to exist, so we can actually produce a margin. But also, and more importantly, because that produces an outcome that affords our citizens access to health care. Because we don't want the prices to go up, we want them to come down.
Yes.
So we can only do that by reducing the overall cost it takes to deliver that care. So it's quite challenging.
I would imagine so.
It is. It's a very complex thing.
Well, it seems like such a baffling, almost bewildering array of different aspects, different things to juggle and put in order. I mean, like an equation that is just phenomenally
multifaceted.
Multifaceted.
I was reading.
Pulling on one string would affect something else.
It does. It does. And I was reading something today about healthcare administration, and they said that healthcare as a industry is probably the most complex organization that mankind has ever invented. and I would agree with that.
Right.
Yeah, it's quite interesting.
Well, I think healthcare, like in the past, it's been conceived of in fairly kind of straightforward terms, almost. So you go to a doctor, something is wrong with you, it's diagnosed, the doctor gives you medication, or you get surgery, and it's thought of in those terms, but it's much more expansive than that.
It is.
When you think of like health and what constitutes
Right.
health, and it's the definition of health,
Right.
and how we promote health.
Well, there's a great example, Chris.
so
You know,
broad.
the system you just described is the historic system. It's transactional.
Right.
You come to me, I do something to you, I give you a pill, I charge you for it, you go home, and we had a transaction, and hopefully you get better.
Right.
But, you know, as we were saying, the new model is that we want to avoid ever seeing you. We want to do things to keep you well and away from us. So,
Although we like you.
oh, we like you as a person. We like you so much we want you to stay healthy and
Right,
not
right,
get
right.
sick. So, you know, there's a great example that we heard at a conference a few months ago, which really sort of gives you a great illustration in the state of Maryland, where they're far further ahead than Vermont is in terms of this payment reform, where they're actually paying providers or incentivizing providers to keep people out of the hospital.
Yep.
So there was this great story the person told that there was a hospital that had a child who kept coming to the emergency department over and over again with asthma. And they'd come in, and the child was in distress, and the child was having an asthmatic attack, and they'd get her all set and send her home, and she'd come back again. And of course, that's not good for the child. And she's coming into the hospital often, which is expensive for the system and for the family.
Right.
So what the hospital decided to do in order to serve that patient better and avoid all these hospital visits, the hospital used its own money to buy the family an air conditioner
Okay.
and install an air conditioner
Right.
in their family home so that the air quality was improved and there was less dust and pollen and so forth, and the child stopped coming to the emergency department.
Right.
So, you know, if you think of hospitals historically, not too often do we buy air conditioners for people. It's just not part of our mission.
Right.
It's not part of what we do for our business. But it is a really, I think, tangible example of what we might be thinking about 2 or 3 or 4 years from now, maybe even sooner, where we're going to be having to think creatively about how we can address people's health issues much further upstream,
Right.
before they have a diabetic,
In their homes. Yeah.
you know, in their home,
Yeah.
in their workplace, you know, not in the emergency room, and certainly not in an inpatient bed, you know. So it is going to be a complete reorientation of the community, of folks who work in administration, and of providers. You know, they're especially some of the providers who've been doing this for a number of years. You know, the old dog's new trick thing. You know, it's some of them. It just doesn't come intuitively to sort of learn a completely new way of thinking about healthcare. But we all have to do it.
I think the other changing, there's been a lot that's changed in healthcare over the years, but the other really drastic shift in America is the whole aspect of consumerism. So if you think about what Ron described, you know, you get sick, you go to the doctor would give you a pill and
Sure.
send you a bill. We really didn't send you a bill, he sent your insurance company a bill.
Yep.
And you had little knowledge, relationship, or care about how that bill got paid or how much it was, because insurance was fairly cheap and everybody had it, cheap to you as a
Right.
consumer. So now, as the prices have gone up and up and up in healthcare, and companies who were providing insurance have realized, wow, this is really, really expensive. It's a big bill. We can't pay it all. They've started shifting a lot of that cost back to the employees. And the employees are now faced with big out-of-pocket payments, co-pays, deductibles, and all of a sudden they're saying, well, wait a minute, why does that MRI cost so much? Can I find it cheaper somewhere else? Or why are you prescribing this medicine when this one is about the same and it's, you know, instead of $10 a pill, it's $1 a pill.
Sure.
And so people are getting more involved in their health care, and they're looking out there for better pricing of their health care, because a lot of them are paying a lot out of pocket for it.
Right.
And that's true everywhere in the country. Those costs have been shifting and shifting and shifting every year. And so there's a huge aspect of we call them patients, but really they're consumers now, that go out on the web, they look for quality scores, they look for pricing,
Yep.
because we have to publish our pricing, and they say, okay, I'm going to choose this doctor at that price, and I'm going there instead of here.
Right.
And so if we're not doing it in a way that is cheaper and with high quality and with a great experience every time you visit us, you'll go find another place to go.
Right.
So we also are trying to make sure that we're marketable and that we can actually produce a product that people want to pay for. So that didn't used to happen in healthcare. It was a very codependent or maybe dependent relationship between a patient and the doctor.
Right.
And now it's very different.
Yeah, and I mean, I've noticed that very much so in my own life.
Yeah.
You know, as somebody who has health insurance, but there are still many costs to juggle and decisions to make, and sometimes it's baffling. It's hard to.
It's very complex. It's hard to sort of really be able to be a good consumer still. We're still a little bit in the infancy of this consumerism, where you know, I think it's not like buying a car. Maybe that's a bad example. You never get a straight price when you buy a car. Or buying a toaster, where you go into the store and they can tell you for sure that this toaster is $29.
Right.
You know, it's awfully hard to be able to tell someone as they're entering the surgical suite exactly what this procedure is going to cost, because there are still going to be variables along the way. And while you're actually in the OR, there may be variables, you know, additional drugs that are needed or additional time that is needed or another specialist that needs to be brought in or something. So, you know, although we are definitely moving in that direction, it is a real challenge for us to sort of be really clear about what it's going to cost for a day in, you know, in the hospital.
So I've had some experiences at Porter. I've been to Porter a few times in my time. I've been living in Middlebury now for about 6 years, and I have to say that the vast majority of my experiences have been overwhelmingly positive.
Excellent.
It's been a great experience.
Excellent.
And you know, and sometimes I'm not there for great reasons.
Right, right, yeah. So well, you know, I've been with Porter for 26 years, and you know, we're not perfect for sure. We have our good days and our better days, but you know, I think that this community really appreciates the hospital and Helen Porter. And our physicians, I think for the most part, you know, we do try to hit that mark of good service and good compassion. I've been a patient more times than I'd like to remember, slamming my hand in the car door, you know, blah, 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 or bringing my daughters in. You know, and I tell you, when it's 3 o'clock in the morning and you've got a child who you've decided needs to come to the emergency department, it's awfully nice to be there in 7 minutes instead of 67 minutes. Right. So I think having a community hospital that's open 24/7, that has an emergency department that's staffed and ready to go, with all the specialties, you know, and good compassionate people, you know, it's pretty priceless, I think. And again, we're not always perfect, but I think that our staff does try every day to do their best. So, and we have a great staff.
Well, we have a great example of, we talked about how lucky we are to have some of the wonderful physicians and providers that we do. They are exceptional. We have some all kinds of good and interesting people delivering health care. But our staff in the hospital, particularly in Helen Porter, are really doing a great job. And I'll give you an example of when I got here and we started really looking at our patient satisfaction scores on our medical surgical unit. We saw room for improvement, and we laid out that challenge to the department and said, we need better scores. We need our patients to be satisfied every day, every encounter. And they have, within a couple of months, brought those scores up into the top decile of a nationwide survey on patient satisfaction. So our staff is doing a great job taking care of our patients and making sure that the experience you have is excellent every time you come.
Right.
Yeah.
And I've seen the staff under some pretty extreme circumstances.
Yes.
So as a police officer, occasionally I've been charged with bringing people to the ER, to the emergency room, who are experiencing mental health crisis or are highly intoxicated or under the influence of a drug.
Right.
So they're very, very challenging people to deal with, and the staff has always been extremely professional, very, very helpful.
Right.
Yes.
So it's always been impressive.
Right.
Yeah.
And you mentioned, you know, the mental health crisis. I think it's important to mention because our staff in the emergency department does do exceptional work every day, but they really deserve a tremendous amount of credit for the work they've been doing in recent years since the closing of the state hospital,
Yes.
and the fact that there's so many more people out in the community who are suffering from some really serious problems, and quite often the Porter Hospital Emergency Department is the last resort for these people. They're on the street, they're having an issue, maybe violent or maybe just a medical issue or whatever, and they get brought to us and we deal with their medical issue, but then after we deal with their medical issue, the question is then where do they go from here?
Yep.
And quite often there's no answer to that question. There's no bed available for this person. There's no, you know, so we have had to hold people in our emergency department for weeks at a time in a safe room which is designed specifically to provide as much dignity and care for these people, but to be perfectly honest, it's not very dignified. It is a holding room. And I think I just mentioned this because I don't know how many people in the community really understand how vast this problem is and how much hard work goes on in the emergency department to really try to keep these people, you know, to have the highest quality of existence they can, well after we've taken care of everything we can take care of as healthcare providers.
Sure.
And we're just housing them. And sometimes these people become violent and they become distraught and they become, you know, disruptive. And I think some of the folks who work in our emergency department are really heroes. You know, they take a lot of sometimes heat and abuse.
A lot of heat. Yeah,
And,
they really do.
and I just want to give them a shout out because it's a big deal. It's not getting tremendously better.
Right.
And as an old emergency trauma nurse, I really do appreciate what they do because it's hard work.
So I know that this topic generates a tremendous amount of frustration within the law enforcement community, and I would imagine kind of doubly so within the medical community and the people really on the front lines of this. Do you know, is there anything going to happen with respect to this? Is there any plan to...
Well, we keep advocating for it
Right.
because we do need a solution for a mental health crisis in Vermont, and this is not unique to Vermont.
Sure.
It's a problem all over the country,
Right.
and I think everybody is struggling with how to take mental health into the healthcare umbrella and treat it as an illness like every other illness, and treat it with respect and dignity and enough resource.
Right.
I think another side of that is the heroin addiction problem that we have in Vermont in particular. It's a crisis. We know it's a crisis. We have one Suboxone clinic that we organized several years ago that exists in our Bristol primary care office. Yep. And we have doctors there. Dr. Emily Glick particularly comes to mind, who was the champion for that program, and they take care of over 100 Suboxone clinic patients just in that practice because there's such a demand, and there's probably 80 other ones that are waiting for treatment. So there's really a deficit of resources to take care of our heroin addicted patients as well.
Yeah, and dealing with crime, you know, approaching this from the law enforcement perspective, what I see over and over again, I work in the school system now, but spent some time on the road as well, working the night shift, and in both those contexts, what I see repeatedly is that the vast majority of criminal activity is related either to mental health or addiction or some combination of those, with maybe some poverty kind of thrown into the mix.
Right.
But it's an enormous issue, and it's taken a tremendous toll upon our communities as well.
It is indeed, and when we look at now moving to this value-based or population-based care model and working with all our colleagues, not in Porter Healthcare Network, but outside, the mental health specialist, home health care, all of our other partners out there in healthcare, we all collectively have to work together on those community problems because there are a lot of them out there that we can do a better job with.
Sure.
Yeah.
Yeah, but I think you're absolutely right. These are community problems, and you know, Porter is obviously a part of that community, and it's kind of front and center with respect to a lot of these issues, but it's way broader than that.
It's way
broader than law enforcement. It's broader than
yes,
than healthcare.
absolutely.
It really touches upon so many aspects of our community, and so many agencies working within our community.
It really does.
I'm wondering if you've seen a shift towards greater kind of community collaboration at Porter. Is there more kind of outreach to other organizations? Are you working more closely now?
Absolutely.
With counseling and
we are definitely trying to. We do have organizations that we're working in as part of that collaborative that we've been talking about with trying to prepare for population-based or value-based care.
Right.
Everybody knows we have to work together, and so
Sure.
we have representatives from all the communities that come from all those provider agencies that come together in our community to talk through. Okay, how are we going to manage this, and how is this going to work? And there are many more questions than answers at this point.
Right.
All we have is the briefest outline of what's been negotiated between the Green Mountain Care Board and CMS at the federal level to allow us to do this all-payer waiver, which we believe is the right thing to do. But it is new, it is unknown territory, and we're all trying to figure out, okay, how do we do this? And what are the policy needs? And what has to be communicated in what order and to whom? And how do we get people on board? Because remember, we're shifting a whole generations of people like me that have been around. We're shifting our mindsets over into something completely new and different.
Yeah. And at a much more granular level to the policy relationships, you know, I think not many members of the community know how closely we actually work together on a day-to-day basis with home health in terms of discharge planning from the nursing home. You know, our nursing home has short-term care beds where folks may get their hip replaced, they need some place for rehab for 3 weeks, then they're going to go home. So, you know, on a daily basis, we're having conversations with home health about how we can share these patients and move them from the hospital to the nursing home and then back home, which is the ultimate goal. And then with the counseling service, there's a crisis team, and you've probably seen them, Chris.
many times.
You know, when the ER needs help with a patient with mental problems,
They come.
They call the crisis team, and these guys come to the ER, and they become our partners in the emergency department. We have a brand new room on our medical surgical unit called the Arch Room, which was provided by the Addison Respite Care Home Organization, a separate nonprofit, a completely different group, but they fundraised and they have provided for 1 room in Porter Hospital and 2 rooms at Helen Porter Nursing Home that are end-of-life rooms. They're beautifully appointed with lovely homemade furniture, artwork, music, you know, a special waiting area for we have lots of large families in Addison County. And when your loved one is in the process of actively dying, sometimes you may have a dozen or 15 family members who want to be there.
Sure.
And if you're just sitting in the hallway of a medical surgical unit, you know, it's not really where you want to be. So we created this suite.
Such
so that
a critical component of
yeah.
healthcare, and for so long
ignored.
Yeah,
I mean,
terribly
really
neglected.
not a focus. And
It's all part of healthcare and the continuum of life.
right.
And we're involved every step of the way.
So there's, clearly tremendous challenges, but it also sounds like a fabulously exciting time as well.
It is.
Yeah.
Well,
And it's been fabulous chatting with you. It's been
Absolutely.
great, but we're out of time.
Oh, cool.
I feel like we could go on for
We'll do it
another
again next
show
week.
at least.
We could talk for days.
Yeah.
Yes.
I didn't even get to share my amusing hospital anecdotes with you.
Well, we want to hear those. We want to hear those
To
at
save
some
them
time
for
in
the
the
next
future.
show.
That's right. That's right.
Well, thank you so much
Thank
for
you.
coming on
All right.
on 5
Thank
Our
you, Chris.
pleasure.
We enjoyed it.
So until next time, drive safe, and may all your mischief be of the lawful persuasion.